Let's get started with the last session of the day. In this, we're going to talk about a comprehensive ECMO system of care in St. Francis Health, back to the patients. The first speaker, my pleasure to introduce my partner, Dr. Zubair Siddiqui, who is a critical care intensivist and cardiac intensivist, joined us here about a year ago, doing a phenomenal job in our cardiac ICU, helping us to grow and helping us to manage the patient in an appropriate way. Please, Dr. Siddiqui.
Good afternoon, everyone, and thank you very much for the introduction, Dr. Banayasi. We're going to talk about patient selection and criteria with some focus on respiratory indications in the session. So to start with, our goals for the day are to understand VV ECMO, why patient selection matters, patients who need VV ECMO, understand who benefits the most from VV ECMO, and sort of get an idea of limitations and contraindications for support with VV ECMO. The first slide here is basically trying to tell us what VV ECMO is. The idea is that we drain blood from the venous side, oxygenate it, and then put it back in the venous side. It does not provide any hemodynamic benefits. It does help us with gaseous exchange. Why does the patient selection matter in these cases? The primary goal of VV ECMO is to allow safe lung ventilation and also to cease injurious lung ventilation. It does not offer cure for the underlying lung pathology. It can only work if the lung can recover, if the patient is deemed transplantable for lung. When neither of these options are viable, the only limited option is withdrawal of support, and this we're talking about in a patient who is often awake and interactive. It remains one of the most ethically and emotionally challenging scenario in the world of critical care. So criteria for VV ECMO, when do we think about it, when do we start it? There's no universally accepted selection criteria that exists. There was a randomized controlled trial, most recent one called EOLIA. It put out a criteria, then ELSO put out a criteria, ADS guidelines put out a criteria. ISHLT has some guidelines for the criteria. Most of these criteria are centered around a PF ratio of less than 80%. That's hypoxemia, and then hypercapnia, which causes your PS to drop significantly, less than 7.25, with a PaCO2 of greater than 60. Earlier is better, so ventilator support of less than 7 days is something to talk about. One of the most common themes that you can see in these criteria is need for reversible lung pathology or a lung transplant candidacy. Murray score is something that came out of the CAESAR trial, which was one of the first randomized controlled trial in severe ARDS. It's based on PF ratio, PEEP, compliance, and chest X-ray findings. There are certain absolute contraindications to VV ECMO, which is agreed upon by most of these criteria. Severe neurological injury, terminal illness or non-treatable malignancy, severe chronic lung disease where transplant is not an exit strategy, and a DNR status. So challenges to patient selection, this is a huge exhaustive list of challenges that we might walk through or talk about before trying to put someone on VV ECMO. I'll try to spend some time on each of these things in the following slides. The first one is age. Age is a linear predictor of mortality in severe ARDS. There's no inflection point that exists, meaning there's no significant age cutoff where your mortality jumps significantly higher. So that makes it really difficult to put a cutoff to age. In the EOLIA trial, patients greater than age 75 are not included. Prone ECMO was another randomized trial which looked at proning patients in ECMO to see if there was any benefit. That also excluded patients greater than 75. Pathology-wise, there are certain pathologies that can have favorable outcomes, certain that do not have great outcomes, and certain they are borderline gray zone pathophysiologies. So community-acquired pneumonia, aspiration pneumonitis, status asthmaticus, primary graft dysfunction within the initial 7 days following lung transplant, and ARDS from drowning or transfusion are usually considered favorable pathologies for recovery for patients who would go on VV ECMO. And then pathologies that are considered not so much favorable are here down in the red. ARDS from non-pulmonary causes like burns, trauma, invasive aspergillosis, pneumocystis pneumonia, and lung transplant greater than 30 days out. The high-risk category where there is still hope that the lungs can recover is necrotizing pneumonia, pulmonary vasculitis, lung transplant recipients between 7 and 30 days, moderate traumatic brain injury, chest trauma, drug and toxin-related pulmonary disease. So the third challenge is about comorbidities and organ failures. Major predictors of mortality in these things are pulmonary fibrosis. If someone has underlying fibrosis, the thought is the lung will not recover. Liver disease is considered one of the major comorbidities. Immunosuppression and malignancy are also important comorbidities to be considered. Newly detected liver failure in one of the studies on ECMO had an odds ratio of about 4.83 for in-hospital death. If you have 3 or more failing organs, there is no mortality for benefit of ECMO in these groups. This is based off the CSER and the EOLIA trials. When you talk about immunocompromised state, it is generally associated with poor outcomes, except for select subgroups, that is post-transplant, the initial ones from the day 1 to day 7. When you have advanced malignancy, it's mostly an absolute contraindication in most of the centers. Half of the deaths in VV ECMO are due to non-respiratory causes, and that's why comorbidities and organ failures are very important to consider before we go and support with VV ECMO. Timing of initiation has been of a huge debate over the past. The biggest message here is earlier is better. Early cannulation done less than 5 days of intubation is associated with significant lower 28-day mortality. Greater than 7 days of injurious mechanical ventilatory support has been associated with worse mortality. In one case series, 77% versus 38% if you take the 7-day marker. There's a greater Paris COVID cohort which showed us that shorter intubation to ECMO interval was independently associated with survival in multivariable analysis. Then there is a national inpatient sampling data from 2025, which kind of challenged the dogma of earlier cannulation. It's a retrospective data which showed us mechanical ventilation duration was not independently associated with mortality. Late initiation was not significantly worse than earlier initiation. But the key message here stays that earlier is better. Duration alone should not be the sole disqualifier. What is important is the degree of harmful ventilation that the patients will be on kind of plays more towards worse outcomes. So the next challenge is about exit strategy and duration of support. VV ECMO is usually a bridge to recovery or to transplant, or in lesser cases to decision. Sometimes we get stuck into this hole of bridge to nowhere, which is basically futility. Prolonged ECMO is not futile. So there's been some retrospective studies which showed us that if a patient were to live beyond 21 days on ECMO support, the duration, anything beyond 21 days, is not predictive of survival to discharge. Even after 120 days of ECMO support, 46% of the patients were discharged alive. So that leads to the question of extremely prolonged runs. And there's some more data, some more retrospective data suggesting that about a median of 94 days, 67% were successfully weaned to recovery. 88% of these weaned patients were discharged. So lungs do take a long time to recover, and hence prolonged ECMO run is, the duration of ECMO support is not a contradictory thing to consider for VV ECMO support. Now looking at it from a different aspect, risks and complications of being on VV ECMO, we've got all the system-wise complications here listed from this picture from one of these studies in JAMA from 2019. You've got CNS hemorrhage, about 3.4%, going up to pretty high rates of bleeding, about 8 to 10%, and then circuit-related complications on the right side. You have the cannula-related complications and the circuit-related complications, patient-related complications, kidney failure, cardiac issues, pulmonary issues. And as we learned earlier, about 50% of deaths in VV ECMO happen because of extrapulmonary causes. Center experience and volume. With the greater Paris COVID cohort, centers that had greater than 30 VV ECMO cases a year had about 60% survival compared to 46% overall survival. So it does play an important role in managing VV ECMO patients and outcomes. ELSO registry analysis, higher annual center volume was associated with decreased hemorrhagic complications, pointing out to better anticoagulation management, and decreased pulmonary complications as well. Nursing care and multidisciplinary team approach. ELSO recommendations are to have one-to-one nurse-to-patient ratio, ECMO physician in the immediate vicinity. But during COVID, we did learn the impact of nursing care and multidisciplinary team approach. When nurse-to-patient ratios were diluted to 1-to-4, the 90-day mortality nearly doubled. That was 62% versus 32% when you have nurse-to-patient ratio 1-to-1. So highlights the need of resources and how intensive resources are needed, especially with these prolonged ECMO runs. A multidisciplinary team consisting of bedside nurse, a respiratory therapist, pharmacist, nutritionist, physical therapy, occupational therapy, ECMO specialists are all vital for therapeutic success. The effect of multidisciplinary team and daily rounds was studied in a retrospective study, and even low volume centers could achieve about 80% survival rates with a structured multidisciplinary team and daily rounding, pointing out to the importance of, again, collaborative care. Palliative care involvement have shown to mitigate the risks of VV ECMO in terms of trying to reach an end strategy. One of the things that we talk about are prediction scores. Can we use a certain amount of scoring things to tell us early on that if this would be a good VV ECMO patient or not? Turns out we did come up with scores, the REST score, the PRESERVE score, and there's another score called preset score. They take into multiple variables. REST score, for example, takes about 12 pre-cannulation variables and gives you a score and tells you if that would be a good outcome or not. But all of these have their own drawbacks. Most of these were developed in pre-COVID era, and they have insufficient statistical significance to be used for individual patient decision making. Especially, they were not externally validated in other studies at all. Most of these scores did not tell us that they're good enough to choose patients who would have better outcomes for VV ECMO. 93% of the centers in a survey reported that clinician judgment is more important than institutional guidelines or even any scores or even any criteria. So then it comes to the question at this point is like, why do VV ECMO when you have so many challenges to doing this? On the left side of the slide, you have, basically I'm talking about conventional management of ARDS. On the right side, what we can do with VV ECMO. So when we talk about conventional management of ARDS, the mortality reaches to a peak of 57% in severe refractory ARDS. With ECMO, there's a chance that we might be able to drop this mortality to 35 to 36%. So pretty much almost as half. In conventional management, there is no rescue option with proven mortality benefit. You have paralytics, you have sedation, you have proning. All of those things to a certain degree have not shown us benefit in mortality. The only thing that we can achieve is appropriate oxygenation, appropriate ventilation. Whereas with ECMO, we've shown and we have known there is 25% relative mortality reduction, and this likely comes from the possibility that we can put the lung to rest. With conventional management, we have these patients on ventilator. Injurious ventilation is continuing to happen. Inflammatory cascade is continuing to happen in the lung. That is of significant risk. And with VV ECMO, we can have ultra-lung protective ventilator settings or even extubate the patients. Conventional management has been associated with significant multi-organ failure related to distributive shock, multiple medications, nephrotoxic things. And then with our ECMO, we have had significant vent pressure and renal replacement therapy-free days. With conventional management, you don't have a path to lung transplant, but there is a bridge to possible transplant with ECMO. So for the right patient at the right center in the right time, ECMO converts a near certain death into an about 65% of chance of going home, and this comes from meta-analysis of the CSER and the EOLIA trials. So for us, when we have any referral criteria, this is the thing that we put out, a PF ratio of less than 150, FiO2 equal to or greater than 80%, PEEP equal to or greater than 10, pH of less than 7.2, and no DNR orders. Basically, at this point, we start discussions about going through the patient and trying to go through all of these challenges and see if the patient would benefit from VV ECMO or not. And that's the end of my talk. Thank you very much.
It's my pleasure to introduce Chris Gordon to give the next talk, Updated in ECMO Management. I would like to say some words about Chris. Chris worked with me in Penn State Hershey Medical Center back from 2010 to 2014. Yeah, and he joined me and did a fantastic job there, and he came with me to Oklahoma City, which we built that program there, did a phenomenal job there, and joined me in San Francisco. And he is continuing to do a fantastic job in helping building the program, helping teaching our staff in a cardiac ICU, and I'm looking forward to his presentation. Go ahead, Chris.
Thank you very much, and I'm happy to be here at St. Francis at Baniusi. Just mentioned, we've been a couple of different places, and we came here in 2024, and since we've been here, it's been great, and I'll show you a little bit of what we've accomplished and kind of talk today about, again, what we've accomplished here at St. Francis, what ECMO means to our program, how we've developed that a little bit, and then some complications with ECMO and success of our programs. As Dr. Baniusi mentioned, I've had the pleasure of working with him since 2010. I actually met him in 2009 when I was still in school at the University of Pennsylvania. I had the opportunity to go to Penn State when he first moved here from Germany, and he's had me hooked ever since. So traveled the country with him a little bit, excited. Our experience at Penn State Hershey, just to get a little bit of background of the programs we've kind of developed and built as they regard to ECMO. In that 4 years, we did a little over 300 cases. And then in 2014, we had the opportunity to come to Oklahoma City. We were there for about 10 years. In that 10-year span, we built a huge shock retrieval program where we traveled throughout the state of Oklahoma, North Texas, Arkansas, Kansas, and did well over 1,000 cases in that period of time. And now we're here at St. Francis, where we've been here for almost 2 years now. And in that time span, we've taken things that we've learned and continued to build upon them, and so far done about 150 cases here. What does that mean? Kind of are we doing a good job or not? I'm kind of very proud of these numbers. This is our survival to discharge outcomes thus far just at St. Francis compared to the ELSO registry. And as you can kind of see, just in the little 2 years that we've started a program here, our VA ECMO survival rates are around 52%, where the ELSO registry is around 46% as of this month, as reported for North America. Our VV, as Dr. Siddiqui mentioned, you try to get around a 65% survival to discharge average. Right now, looking at ELSO registry, they're around 58%, and what we've accomplished thus far with small numbers, 61%. And then, as a new program, we haven't really started an ECPR program, and you heard about that in some of the other presentations, kind of the groundwork and the resources that are required from an ECPR program, but we do that on a limited basis here. And currently, with the 6 patients that we've had, we have a 24% to discharge compared to nationally. Through ELSO, it's about 30%. ECMO, as it's evolving over the years, we're seeing, and as people have alluded to, ECMO is becoming more and more mainstreamed because it's no longer being viewed as a rescue therapy. And as that, I think you've heard throughout most of the presentations that early identification leads to better outcomes. If you can identify people faster, if you can get them on support faster, if it's not waiting until people have completely decompensated to beyond points of no return, you have better outcomes. So ECMO is becoming more part of a treatment option versus just rescue and last ditch. And as I think was talked about a little bit in the last presentation towards the end, when I looked at, before I started this presentation, I actually Googled and asked ChatGPT and asked Google, their AI version, what is the future of ECMO? What is up and coming in ECMO? How do I present that in a 15-minute presentation? And all the AI said was AI-driven ECMO. You know, everything said the future is going to be some AI-generated predictive model that's going to tell us who is going to get ECMO, who's not going to get. And I think, you know, we're getting there. As you've seen, as we've talked about, there's limited scoring right now to get to where we need to go. But timing matters. Initiation of support within 24 hours leads to improved outcomes. All right, we want to try to avoid the too late cannulations. All right, how do we do that here at St. Francis? I think again the theme that you've heard throughout this presentation is a multidisciplinary team approach. You know, these patients are very sick and have multitudes of problems with them, and not only identifying them at an early point in their disease process, but also having a team that can discuss all the different tools that we have in the toolbox and how to transition them from point A to point B to point C, not forgetting we need to get them back to a quality of life that is meaningful to that individual. And that takes more than one person. And we feel that we do that very well here. As it goes to get to patients very early, it involves, you know, kind of outreaching who can place somebody on support. How can we get to these people to the devices that they need? We have an intensivist-led program from an ECMO standpoint, not a surgical-driven program. We feel that that allows us to give 24/7 support to the patients when they need it, whether or not that's 2 o'clock in the morning or 2 o'clock in the afternoon. We have somebody who's available to initiate support and get these patients the treatments that they need at a very fast time. Here also at St. Francis, we're implementing a retrieval program, all right, leading to a development of a regional network, allowing patients to get access to high-volume center as well too. One of the things that you've heard, again, throughout all these presentations is getting patients from outlying facilities to where that the expertise really is and has every tool on the shelf to kind of move people from point A to point B to that ultimate survival to discharge. All right? We've implemented a dedicated ECMO and shock hotline. So we have a number that's held by a clinician 24/7. So any outlying facility can reach a physician 24/7 to discuss a case, to determine how to transition somebody across that healthcare paradigm. And then currently, we're still in the works of it, but we utilize on our local EMS right now, but we have a mobile ECMO program that allows us to move between different hospitals if we need to go somewhere to cannulate somebody for ECMO and bring them back to our facilities. We're able to do that as well too. One of the things that we pride ourselves on being able to help out with this too is the sickest people of cardiogenic shock are those who are needing support coming off of cardiopulmonary bypass after cardiac surgery. People who can't be stabilized with inotropes and pressors and are spending prolonged periods of time on bypass. We have the capabilities and the infrastructure to help go to those facilities, stabilize them with ECMO off of cardiopulmonary bypass, and then bring them back to our facilities. And that's, again, driven by an intensivist-led program, not surgical-driven. This is just some pictures of us in the beginning of our program and kind of what it goes into transporting. If you've ever seen somebody who's so sick on ECMO, what that looks like. This is somebody who's on ECMO, who's being brought into the back of an ambulance. All right. This is somebody who's on ECMO and Impella that's getting ready to be mobilized to our facility. All right. Some of the things that's allowed us to do this, you know, over the years, been doing this, you know, again, close to 1,500 patients over 15 years. Technology has come a long way, and it's allowed us to offer these devices to a lot more people because technology has picked up as well too. We now can rely on much smaller circuits, all right, more portable devices, all right. This allows us to make a system that's much more simple and more people can utilize and we can transport with. ECMO no longer needs to be this big giant contraption that has multiple feet of tubing, have multiple bridges, reservoirs, pigtails. We've been able to simplify that all down so that it can now become a modality that we can go to outside facilities or we can cannulate somebody on a medical surgical floor, not necessarily be limited to an OR or a cath lab. We can do this in a high variety of places. Oxygenators have improved, which have larger surface areas, lower resistance, become, in short, more biocompatible. All right. As technology has become more biocompatible, a lot of the risk profile of ECMO has been able to be reduced, and we've been able to extend the time we can offer people to recover. The other thing that we've done here at Integris, and we've worked hard at all of our programs, is demystifying ECMO, simplifying it. If you look back at ECMO, 15 years ago, it took a multitude of people to sit at the bedside to run this machine, to keep the patient safe and try to minimize all of those risks. Because technology has improved, because we've been able to simplify it, and we've learned so much about the patients that we've cared for, we can now shift to a more nurse-driven model. All right? Here at St. Francis, the only person that sits at the bedside is the nurse who's caring for the patient. All right? We've been able to demystify and simplify the process enough that we can teach the nurse just like we teach the CRT machine. We can teach them about the ventilator. We can teach them more about let's care for the patient and what are the tools that can help facilitate that. Here at St. Francis, we put all our nurses through a 2-day course. All right, they get a full didactic training for 2 full days. They get stuck listening to me in the classroom, and then afterwards we do a one-on-one competency checkoff, and then they're kind of prepared on the learning process to care for these patients. As Dr. Siddiqui kind of mentioned from a ratio, what we learned from COVID, we still keep 1-to-1 ratios, but the big part is that we no longer make things so complicated that we have to have somebody else to sit the bedside. 20 years ago, a perfusionist would have to sit the bedside. 5, 10 years ago, we would keep 2-to-1. We'd have nurse ECMO specialists or so forth, in-house 24/7. We've been able to find a way to minimize risks, all right, and simplify the process so that we can offer ECMO to a higher patient population. And all of these things that kind of talk about next is how we've simplified this and how technology has allowed to do this. We've become more aware of the bleeding risks that go on with ECMO. How are these machines affecting our bodies? Improved biocompatibility of the devices and tubings had allowed us to be less aggressive with anticoagulation strategies. We don't have to have complex anticoagulation protocols. We simply sometimes keep people on heparin just 30 to 40, all right, with a PTT. That minimizes their risk greatly without seeing increased thromboembolic events. Ventilator strategies. As technology has allowed to keep us on ECMO for longer and longer periods of time, we certainly can't keep people on a ventilator for 1 week, 2 weeks, 3 weeks, 4 weeks, as we are allowed to support them and allow their hearts or their lungs to recovery. So we have to think of new ways to keep people no longer bedridden, all right? And this idea of awake ECMO, no longer over-sedating them and trying to treat needing to be on norepinephrine because I've got to keep this person on 10 milligrams of Versed to keep moving. That is all things of the past. We want people up, moving around so that we can bridge them to whatever their next step or allow them to recovery. So we focus very much on early extubation and early mobilization. One of the key things that's helped us with early mobilization is moving from dual site cannulations to more single site cannulations. We now have cannulas that allow us to just put one hole in somebody, one cannula in somebody, and allow for PT and OT to occur at a faster rate. This is some of the things, hopefully the videos will play. This is a lady who was on VV ECMO for weeks as she was being evaluated and bridged for a lung transplant. And you can see, this has almost become, it's kind of choppy, but this is somebody who's on VV ECMO for, I think at this point in time, she was 3 weeks on support. And one of the things I want to point out with this video, not only is she up and walking in the hallways, not just in her room, but there actually is no physician in this picture at all. This is our physical therapy and our nursing department doing physical therapy with this individual. So do we still need a village to care for these patients? Not necessarily. We just need the right training and infrastructure to really help these people move across the system. This next video is actually somebody who's on VA ECMO. He's on peripheral VA ECMO through his groins. He was a gentleman who came in with a late presenting MI and had a VSD. And as we know, with VSDs, before a surgeon wants to take them to surgery, they need weeks to develop a scar so that the repair can take. Should we keep that person intubated and sedated for 2-3 weeks while they're waiting for surgery? They probably would have worse outcomes. So how can we now create a system and create a team that continues to push the envelope of improvement? And we've got this guy up and walking, and he actually, we had to stop him. I cut the video short, but we had to stop him. He wanted to do a lap around the unit, but we didn't kind of feel comfortable. Kind of go quicker real quick. Hemodynamic management of VA ECMO, we provide full cardiopulmonary support. One of the things that we do focus on and was talked about a lot here is LV distension issues. We utilize pulmonary artery catheters significantly. All of our VA ECMO patients, we use PA catheters so we can look at the wedge pressure. We do routine echoes every 24 hours. And early identification, if somebody's not tolerating the VA ECMO, can we move across the treatment, and do they need different unloading strategies, either with a CP or an Impella 5.5, all right? We've standardized weaning strategies, so with VA ECMO, again, for improvements, we do echoes every 48 hours. We drop the support by about 50% to see how the LV is recovering. This allows us to identify people who are starting to recover or people who might need longer terms of recovery and maybe transitioning to a 5.5 or keeping them where they're at. Continuous hemodynamic assessment, echocardiograms, and we've protocolized these weaning trials so that we're trying to identify patients where they are in their disease process. VV ECMO is the same way. Daily assessments of gas exchange and protocolized trials off the gas blender. We talk about prevention and management of acute complications. We published this a couple years ago in the Annals of Cardiothoracic Surgery, looking specifically at VA ECMO and its prevention and management of acute complications with a intensivist-led model. And again, we were able to demonstrate that with a dedicated 24/7 ECMO surface using a multidisciplinary team and defined protocols, we were able to effectively reduce complications found on VA ECMO. And again, these are the outcomes that we looked at. We separated the different adverse complications, bleeding, hemolysis, neurologic events, and with a 24/7 multidisciplinary team, we were able to prove better than in most categories compared to the published literature at that time. And a huge part of that is, again, the multidisciplinary team. All right. Also, improved biocompatibility that we've seen of the technology that we're using has allowed us and afforded us to reduce our anticoagulation requirements. Lower limb ischemia, we always routinely use distal perfusion catheters. We use tissue oximetry. We teach our nurses to do frequent vascular checks. We routinely use pulmonary artery catheters for hemodynamic monitoring, routine echoes to make sure that we're not missing people who are spending time with distended LVs that they may need additional LV unloading. Infection, we use surveillance cultures a lot. It's somewhat controversial. We use empiric antibiotics, early initiation and escalation of antibiotics. And then with neurologic, again, some of the bigger things that we've seen with neurologic is if we're going to have bleeding complications, it's because we're on excessive anticoagulation. The technology that we have today has allowed us to spend time with patients on mechanical circulatory support without being on anticoagulation or on very minimal anticoagulation with very little thromboembolic events. Again, key takeaways from what we've accomplished here at St. Francis. Again, viewing ECMO not as rescue therapy, but integrated into our critical care support algorithms. Defining when early identification of those patients. A simplified approach, dedicated regional center, and again, it takes a team of specialists to care for these patients. So, thank you. I apologize for going over.
Our next speaker is Dr. Delgado. She's an internal medicine resident from Oklahoma State University, and she'll be doing a case presentation on VSD to recovery.
Thank you, Dr. Siddiqui. Hi, everyone. I know I'm the last one for the day, so I'll try to keep it short, and hopefully you're engaged. So this is a case about rupture repair and recovery, mechanical support strategy in post-MI VSD. So this patient is a 62-year-old male with a past medical history of type 2 diabetes and hypertension, no known prior cardiac medical history. Prior to admission, 3 weeks prior to admission, he had an episode of shortness of breath and diaphoresis, which he attributed to the flu and decided not to seek medical attention. 3 weeks after, he presented to our emergency department here with progressive dyspnea and swelling of his lower extremities, ultimately shortness of breath, and pink sputum. His vitals, he was hypotensive around 70s, 80s systolic. He was also tachycardic. Labs were notable elevated for troponin of 5.4, high BNP, lactic of 5.6, glucose in the 500s, and elevated transaminitis. At this time, he was admitted for concern for septic shock versus cardiogenic shock, and he was started on an insulin, Levophed, and heparin drip. This is the initial EKG that shows sinus tachycardia with anterior septal Q waves in V1 and V2 with concern for LAD involvement. And then this is the initial echocardiogram, which I hope you can appreciate. It shows anterior apical akinesis with a low EF around 20% and a VSD. And the Doppler ultrasound, what you see is a very high jet across the septum that suggests a left to right shunt. And so at this point, he went to the cath lab. His cardiac index was 1.3, which suggested cardiogenic shock. He was also found to have an LAD occlusion about 99% and mid left circumflex stenosis and RCA at about 30%. There was a multidisciplinary talk, which I think that's the theme of the day, about what was going to happen next with this patient. And at this point, it was decided that he would go from the cath lab to the OR to get Impella 5.5 placement via the right axillary artery. And this is his initial cath. And what I hope you can appreciate is that LAD occlusion, that's about 99%. And so he was on admission, by the way, this is back in 2024. On admission, he had that Impella 5.5 placement. The flows were titrated properly to try to avoid pulmonary edema and right to left shunting, which I think we've all heard about today as well. A day after admission, he did have some ventricular arrhythmia. He requires shocks and also antiarrhythmic medications. And then about 17 to 18 days later after admission, he underwent surgical repair of the VSD with a double patch technique and single vessel CABG to his LAD. Impella was left in place, and he required escalation to VA ECMO as well. And so for about 7 days, he was on Impella, which it was a combined support for LV offloading and at the same time LV afterload. And then a day after his original surgical repair, he ended up having to have an exploratory hematoma with a physiology of cardiac tamponade, and then had to go back to the OR the same day. He did require multiple vasopressor supports and ionotrope support. However, he gradually recovered. He was decannulated from ECMO, and then Impella was later removed. His repeat echocardiogram showed an improvement to EF of 35%, and he went home with an ICD for secondary prevention. He was discharged home about a month later after admission with home health and home PT. Follow-up, he's doing really well. On his first follow-up appointment, he was up-titrated on GDMT. He stated that he walked about 40 minutes every day at the Gathering Place, which if you're from out of town, you should check out the Gathering Place. It's a really nice park. And then he also said that he mows his yard, and his LVF was around 33% at this time. And then his most recent follow-up appointment was earlier this year. He once again says that he does not have any worsening symptoms, continues to go to the Gathering Place, goes up and down the stairs with really good recovery. And so now I want to talk a little bit more about the pathophysiology of VSD and why this case was so exciting for us. One, post-MI VSD, it's a pretty rare complication because it has very high mortality rate. If it's left untreated, it has about 94% to close to 100 mortality. In those cases that are intervened through interventional treatment, they have about 55% mortality rate. And then for those that undergo surgical treatment, they have about 44% rate. And so what happens is when you have the initial infarct to the side, the septum becomes necrotic, weakens, ruptures, and then you have a connection between the left ventricle and the right ventricle, having that left to right ventricular shunt. And so this is not just a pump failure, but it's also a closed circuit loop that it's within the pump that's failing. And so we've heard about Impella and ECMO, VA ECMO and ECPella. And so for this case specifically, we kind of talked about it, or a lot of people talked about. For Impella, you have the decreased LV offloading, but too much or excessive offloading can lead to right to left shunt. And so in our case, he was escalated to VA ECMO as well, which increases the LV afterload, kind of helping have a balance between those two forces. And so while one helps us with one physiology concept, the other one may be hurt. And that's why for this case was chosen to be more of an Impella case. And so the other thing is, what's the timing for a VSD repair? Whenever you have a acute case and the person needs emergent, either surgical or surgical repair pretty much, the tissue is very fragile. And so while the patient can go and have repair, there's a very high mortality. In our case, the patient had the Impella 5.5 placed, and then about 2 weeks later, he underwent surgical repair. And so the downside to that is that sometimes we wait and the patients don't make it till the surgery date. Thankfully for our patient, in our case, he made it through the waiting time while his muscle recovered a little bit more and then had a successful surgery. And then we go to the surgical versus interventional technique. The gold standard continues to be surgical approach, and there's still a lot of data that needs to be completed regarding what's better and what case do you use which approach. In our case, it was a very large impact to the septum, so the patient also needed a CABG for that LAD approach, and so we decided to go with that surgical approach. And so last thing, we talked about the multidisciplinary team decision making. I think when we know that the cases like this are coming into the hospital, it's good to have that communication between not just the intensivist, but also the cardiac surgeons, cardiologist, and then the whole nursing staff and the entire team. And I think what all of us have emphasized is that it's not just about what happens in the hospital and what we do medically or interventionally, but what happens when the patients leave, right? How do they have the good support system? Do they have the social barriers of care? How are they going to get to their PTOT appointments? And so I think it takes a village for these patients to fully recover and have a successful outcome. So that's it. Thank you.
Thank you very much. And I would like to start the panel discussion with the audience to see, I would like to hear some questions from the audience to the speakers. Yes, please go ahead.
I think Dr. Siddiqui.
Can you take the microphone, please, that everybody can? And introduce yourself.
My name is Kay. I'm a medical ICU nurse, and so Dr. Siddiqui, I'm very interested in the VV ECMO. Given the chance for VV ECMO patients to be extubated and then be mobile, ambulatory, communicative, not sedated, therefore not having the chance for delirium, post-intensive care syndrome, all of the things that we see with our ventilated patients so much, unfortunately, do you foresee that the criteria for patients to go on VV ECMO, do you see those changing, becoming maybe less stringent so that more patients could have the opportunity for that and get extubated, mobilized, et cetera, sooner? Thanks.
Thank you very much, Kay. That's definitely a great question. I think the enthusiasm is there to try and do early ECMO and see if we can get away from all the harmful effects of medications, mobilize them, decrease the incidence of delirium and everything. But that being said, it needs to be balanced with the risks and complications that come with ECMO as well. There was a slide in my presentation, huge list of complications, all system-wise and everything. I would say it would be difficult to do that. Right now, where we are is ECMO remains an escalation parameter rather than early on, even going before intubation or right after intubation.
It's an excellent question. Chris, what do you think?
No, I mean, I think if I had my way, I'd put everybody on ECMO before I got them intubated. No, no, but I think there is. I think as adverse events, I think as technology has improved, I think that you know the inclusion criteria for putting people on ECMO is going to get larger and larger and larger. I think it's just, again, it's weighing the risk benefit and finding that timing of when it is, because you don't want to put people on ECMO and then 24 hours they're able to come off of it. So it's kind of finding that right balance. And I think that's where, again, a multidisciplinary team approach comes into play. And I don't think there's ever anything wrong in calling an ECMO consult or calling a consult and say, hey, I've got this patient who's intubated, who, you know, maybe we're still teasing out what the disease process is. You know, could they be evaluated for ECMO? Would they benefit from a VV ECMO? And you know, it might be that, okay, on day one, they're not a candidate for ECMO, but now you've got that team following them to, again, identify, are they recovering? Are they getting worse? You know, maybe it's not day one, but maybe it's day 4 that they need to be initiated on ECMO support. I think that's where the multidisciplinary team comes into play. So I think there's never anything wrong with calling an ECMO consult because it gets the team involved.
Dr. Stewart?
As well. We have a question in the chat. Or
Okay.
do you want to go first, Dr. Ansel?
I think that's an excellent question without a clear answer, frankly. I will say I think there is a role for involving multidisciplinary care early. If you actually look at some of those few trials that were RCTs that we do have on ECMO, Dr. Siddiqui mentioned the Aeolia trial, there was a significant portion of patients who were transferred to an ECMO center or had the team involved and ultimately did not end up on ECMO but still had better outcomes. And I think that just reflects asking these questions early, involving multidisciplinary care more so than the pump device itself.
Thanks. So my hospital actually is OSU, so we don't have the fancy machines that you guys have here. So anytime that we have an ECMO consult, it's really nice when we get to call the experts here and we tell them what's going on with the patient. Can the patient be possibly evaluated for ECMO? And even if the patient doesn't get transferred, at least we know that we're getting advice or some type of expertise from the team here. And so I think it's kind of like the other case that was presented earlier today. When somebody gets transferred from a smaller hospital, we know that they're getting excellent care here. And if they don't, then at least we know that we can always call. And I think that's why the 24/7 hotline is really important.
I think I'll repeat that again. It's a really excellent question, and I think we don't have data to support go earlier on VV ECMO patient to support such kind of approach, and I think to have such to have a consult and to ask for that and to let the multidisciplinary team to decide about that, I think is the best approach we can do for the time being. ECMO is still evolving, technology is improving, and that one day we might be able to do that. But I think for the time being, still, we don't have enough data to support such kind of approach. But again, that's really fantastic question. Yes, please, Dr. Inslee.
Ali, I know this is really a question for you. I know you go to a lot of specific device-related meetings, new technology coming. So I watched the evolution. 1969 till 1993, the only heart replacement therapy was heart transplantation. And there's a whole world of people that aren't a candidate. And then mid-1990s, we had LVADs, which expands heart replacement therapy to people who are not transplant candidates. So I've seen prototypes and videos, but from your meetings, how far away are we from the LVAD equivalent of lung replacement therapy? So I've seen extracorporeal, portable ECMO stuff. How far away do you think that is?
The main challenge with the, from ambulatory ECMO compared to ambulatory LVADs is oxygenator technology. We're far behind, honestly now, and we didn't invest enough in oxygenator technology. That's a technology gap. When we're meeting together with engineers, is a technology gap. I think that's a major obstacle for us to move forward. There was research not to say even studies in the past was intravascular oxygenator. Didn't work because of the clotting we have. That was a Mortenson oxygenator. We did that in inferior vena cava and to try to oxygenate the patient. Didn't work. I think I cannot predict that in the next 5 or 10 years we have that. Even that we look to the breathe system, which was invented in Maryland, in Baltimore, from Barty Griffith, and was acquired by Abumane. It didn't work well. That means the system was innovative because they extracted oxygen from the air. You don't need an air tank to get to that. But they have multiple technical issues with that. Abumane bought that and tried to revamp it and to bring that again. I think before 10, 15 years, Doug will not be able to see that.
Okay. We need it. It's a huge gap.
Have any question from the audience? Please, go ahead.
We have one in the chat from Pradyumna Agasti. Are there any considerations for LAVA, L-A-V-A, ECMO in post-MI VSD shock?
Yes, answer this question.
I mean, I can't speak on it for our experience. We've not utilized that. I don't know if you different answer you're looking for, Dr. Baniasi. I don't have any experience doing that.
Was what?
With LAVA? With using the question using LAVA in post-MI VSD? Yes.
Considerations for LAVA, ECMO, and post-MI VSD shock?
Yeah.
Just for clarity for the audience, it's basically putting a cannula from the usually right femoral vein across the intraatrial septum towards the left atrium and draining there, that being your arterial cannula, in a way of having atrial to aortic bypass, so bypassing the ventricle completely. And it's a technique that's being used mostly in the interventional cardiology structural world for situations like VSD, mechanical valve, mitral thrombosis, and mostly done in areas in which you don't have access to surgical implementation, rapid surgical implementation. And it's a good series from Detroit coming up, but not really something that I have seen adopted across the United States.
We don't have experience with that. I don't have my personal experience with that. Any other question from the audience? I have a question regarding cannulation in VECMO. What kind of VECMO? What kind of strategy the team think is the best for the patient? How you are, selecting your cannulation technique? Is it dual side versus single side? How you choose that?
I think the way we've been doing it so far is we prefer single site cannulation if you're thinking that we can early mobilize the patients and everything. The significant limitation to that is obviously flows. You would not be able to get higher flows, 32 French versus if you're able to put dual site bigger cannulas, you can go up to 25 and 21, it's like 46 French or something. So that's another approach. And sometimes we have patients who are in distributive shock, not really clear why they are in distributive shock, so that in that kind of situations, I think it's helpful to have dual site cannulation in case you have to escalate it to VA support or something like that. And that's usually the thought process initially.
Chris?
So I personally, through my experience, I think that single site cannulation is my preference, because I think that some of the culture limiting barriers to physical therapy, to waking people up, to getting them up to early extubation or early mobilization, there is still a lot of hesitance to do that when you have a large bore access in people's groins, and even if you get to the point where you're able to convince that yes, people can wake up if they kick their leg, if they move their leg, nothing's going to happen with the cannula, and you can get them extubated. Then the barriers of saying yes, we can sit on the side of the bed, we can walk with large bore cannulas in our groins. That all of that gets eliminated with a single site dual lumen catheter. So in my experience, and again, I don't have a randomized controlled trial to support this, but if you looked at timing to PTOT, timing to extubation, I would guess that it would be sooner with a single site than versus a dual site. I think the limiting factor sometimes for me of why dual site versus single site is what does the patient look like. With single site using a crescent, because we're going down the superior vena cava through the right atrium into the inferior vena cava, we still do that under ultrasound fluoroscopy. So we need a little bit further advanced imaging to get this done. Whereas with dual site, you can just use an ultrasound and away you go. So depending on where we're cannulating somebody, depending on the resources that we have, whether or not they can lay flat is some of the limiting things to dual site. But I think single site is superior.
Sure.
I will say I become a believer in single site, assuming, as Chris said, patient anatomy can tolerate it, particularly the larger bore cannulas, because you can flow respectable amounts. I've seen flows of 7 liters on 32 French crescent cannulas. The challenges being it's more resource intensive. If you're doing a retrieval at a location that may not have fluoro available, you may be more limited. But I trained and initially practiced at a institution that was predominantly dual site, and even though you can ambulate patients with cannulas in their groin, there is a hesitancy to do so, and it becomes a barrier to progressing care. You also face other issues like recirculation that can become challenging in certain circumstances.
And I would like to add as a question to that regarding the BMI. We live in Oklahoma. We know that the average or median BMI is very high. Is any cutoff for BMI in VA ECMO? You say above this BMI, we're not going to do it. Where something is
With VV or
do you
VA?
think about that?
With VV or VA?
VV.
For VV. I don't, my experience, I don't, we have done people with large BMIs, say over 40, 45, that have tolerated single site VV ECMO and surprisingly gotten out of bed and walked. I think it's a technical risk, but it's not an absolute contraindication.
I don't think I would agree with Chris. I don't think it's an absolute contraindication, but probably could be taken as one of the considerations among many different things.
I concur. I think, though, above a BMI of 45 to 50, anecdotally speaking, I only have a few cases where we've done it, but it's become significantly more challenging.
I think the biggest BMI was the largest BMI we cannulated patient with was 65. That we did that. Even the patient was walking with single site cannulation. Why I'm asking that here is just to encourage the people to consult for ECMO even with high BMI and to have that in a multidisciplinary way to have the answer for that. Any other questions from the audience? Well, if we don't have question, I would like to pass the microphone to my colleague, Dr. Ensley, to give a closing remark, and thank you everybody. Thanks everybody.
Good. Just want to say thanks to those of you that stuck it out all day, particularly thanks to everybody who came. So much thanks to Dr. Hernandez, who brought a wonderful faculty from all over the country and out of the country. Thanks to Education Department. Huge thanks to Tracy, who just killed herself over the last few months to get this done. She was a taxi driver last night back and forth to the airport. She was everything. And then finally, just huge thanks to the administration for all the support we've had over the last 3 years. It's been an amazing run, and exciting to step back and watch what Dr. Hernandez does next for us, along with Dr. Banyasi and additional surgical recruits to come. Have a wonderful day. Thanks for spending time with us.